Hello, all. Today's discussion will be on the topic contact and contour. Myself, Dr. Kripa, Senior Lecturer, Department of Conservative Dentistry and Endodontics, Royal Dental College, Challenge. So today's discussion will be coming under the following topics: introduction, contacts and contours, embrasures, marginal ridges, how to create proper contact and contour, and conclusion. So the presence of proper contact and contour is important to maintain a very stable occlusal harmony. So as a clinician, you should have a thorough knowledge about the same. Otherwise, this will be a predisposing factor for caries because of the faulty interrelationship, the significance of marginal ridge and embrasure to reestablish the form and function of restored teeth, and the periodontal aspect and health of tooth to be restored. So what all are the benefits of an ideal contact and contour? This will conserve healthy periodontium, prevent food impaction, makes a self-cleansable area, improves longevity of proximal restoration, helps to maintain normal mesiodistal relationship of teeth and dental arch. So as a dentist, we play an important role in establishing the ideal extension so that the tooth can perform well in the oral cavity for long. Whatever food we consume will move in three directions: occlusal, facial and lingual, and across the contact and embrasure. Any decay on the proximal aspect is usually due to a faulty interrelationship between contact area, marginal ridge, embrasures, or gingiva. This is very important. At the time of eruption, every tooth will have only a point contact. Due to the physiologic process of attrition, the proximal contact point becomes a proximal contact area. So proximal contact area is the area of height of contour of mesial or distal surface of tooth that touches the adjacent tooth in the same arch. According to their general shape, there are three types of teeth. You have tapering teeth with wide crown and narrow cervical area, square type teeth with bulky angular with little rounded contours, oval type as a transitional type between the two. Sorry. So the shape of teeth varies according to the shape of arch form. If it is a square arch patient, we are taking into account now the incisors. His incisors will have parallel sides. If his arch is tapered, the incisors will have a triangular form with a narrow neck. If it is ovoid, incisors will be rather ovoid or rounded. So, based on that, the contact will also be different. Here we are discussing about the tapering teeth. For a tapering teeth with an incisor apically, the contact is at the incisor edge. Labiolingually, it is labial to the incisor edge. Compared to a canine, the mesial contact will be closer to incisor edge. Distal contact is more or less centered on the distal aspect. In the posterior teeth, the location is near the junction of incisor and middle third, or rather in the middle third itself. So based on the teeth, you can see based on the shape of the teeth, the contact is also quite different. So for a tapering teeth, we have already discussed. Now for a square tooth, you can see that the contact between incisors is at the incisal edge with the labial incline, just like a tapering tooth. But coming to an oval tooth, the contact is a bit lingual to incisor edge. Mesial contact starts 1/4 of the crown incisor-gingivally. Distal contact starts 1/3 to half crown incisor-gingivally. Coming to canine, for square it is like a tapering only. In ovoid, it is more closer incisor. Then coming to bicuspids, for tapering, the buccal periphery is at the buccoaxial angle. Occlusal periphery at the junction of occlusal and middle third of crown. Contact deviates buccally. For a square tooth, buccal periphery is buccoaxial angle. Occlusal periphery at the occlusal third. For ovoid, buccal periphery comes at the junction of buccal and middle third. Coming to molars, buccal periphery almost at the buccoaxial angle of tooth for tapering. Occlusal periphery at the junction of occlusal and middle third of crown. This is the mesial contact. For square and ovoid, the mesial contact is just like premolar. That is buccoaxial and occlusal third of square at the junction of buccal and middle third for ovoid. Whereas the distal contact of molars is in the buccal periphery at middle third for tapering tooth, more lingually deviated than mesial for square tooth. Buccal periphery in line with central groove for ovoid. Regarding embrasure, for tapering, wide variation of incisal and labial are negligible. Gingival and lingual embrasure between anterior will be the widest and the longest in the mouth. Buccal embrasures are small, lingual. For square tooth, incisal, lingual, occlusal, and buccal embrasures are nil. Gingival embrasure is also not so noticeable. When the tooth is ovoid, incisal, labial, buccal, and occlusal embrasures are wider and deeper. Gingival and lingual are short and broad. So why did I discuss the entire thing is that you should understand, based on the shape of arch, the tooth shape varies. Based on the shape of tooth, embrasure space, contact area, everything varies. So when you restore a tooth, we should have a clear-cut idea about what is the shape of the teeth and where the contact is. Then only you can restore it in the physiological way. Next is about contour. The convexities on the facial and lingual surface of tooth that affords protection and stimulation of supporting tissues during mastication. So contour helps in deflecting food, maintaining the periodontium, and maintain a contact with adjacent tooth. So here is the important term height of contour. It is the area of greatest circumference on the facial and lingual surface of the teeth. This protects the gingiva by preventing food impaction. So in the anterior tooth, the height of contour is in the cervical third on the facial and lingual surface. For posterior, it is in the gingival third on the facial surface, middle third on the lingual surface. So the type of contour, if it is adequately contoured, you have adequate stimulation of supporting structures and a healthy periodontium. If it is over contoured, the food will get deflected away from the gingiva, lack of stimulation of the supporting structure, and lot of plaque accumulation. If it is under contoured, there is going on continuous irritation of the soft tissue. Next is about embrasures or spillways. They are the V-shaped space between the teeth that originate at the proximal contact area between adjacent teeth. The curvature formed by the two adjacent teeth in an arch forms a spillway space that is called as embrasure. They serve mainly two purposes: providing a spillway for passage for food during mastication, preventing the food from being forced into the contact area. Based on in which direction the embrasure radiates, can be facial or buccal, lingual or palatal, incisal or occlusal, and gingival. Gingival embrasure is filled with endodontal papilla, preventing food from being entrapped in the area. In anterior tooth, the papilla is triangular. In posterior, they are cone-shaped. Correct relationship of embrasure, cusp, sulci, marginal ridge, and groove of adjacent and opposing tooth provide a proper escape or spillway for food when you masticate. If the embrasure space is reduced, there is additional stress created in the tooth and it affects the supporting structures. If the embrasure is large also, they get entrapped and there is more of defect to the supporting structure. Lingual embrasure is greater than buccal since tongue can displace food occlusally. Next is about marginal ridges. The rounded borders of enamel which forms the mesial and distal margin of occlusal surface of molars and premolars and the mesial and distal margin of lingual surface of incisors and canines. They are always formed in two planes, buccolingually meeting at a very obtuse angle. This feature is essential when an opposing functional cusp occludes with the marginal ridge. Function of a marginal ridge is preventing food impaction proximally, enhance mastication, and protecting periodontium. Marginal ridges of adjacent posterior should be at the same height to create proper contact and embrasure form. So this is the marginal ridge which is in the normal occlusion. You can see that the way the force is distributed is uniform along the long axis of the tooth when there is correct occlusion with same marginal ridge level. Marginal ridge with an exaggerated occlusal embrasure will cause tooth to be drifted and hence food will get entrapped, wedged. Adjacent marginal ridges are incompatible in height, driving the debris in the proximity. Marginal ridge which lacks triangular fossa, the vertical forces will impact food in the proximity. If the marginal ridges are thin, there is susceptibility to form, deform, or fracture. A marginal ridge with no occlusal embrasure, the two adjacent marginal ridges will act like a pair of tweezers, grasping the food which passes over it, getting entrapped. So that was about the features of contact, contour, embrasure, and marginal ridge. So now we have a clear-cut idea regarding the importance of all these. What will happen if there is an improper contact, contour, embrasure, and an incompatible marginal ridge. Now we move on to the procedures which help in achieving this proper contact and contour. First is tooth movement. The act of separating the involved teeth from each other, bringing them closer, changing their spatial position in one or more dimension. The objectives of tooth movement is to bring drifted, tilted or rotated tooth to their physiological position, to close space between teeth which is not amendable to closure by restoration, to move teeth to a physiological position to move teeth occlusally or empirically for the ease of restoration, to move teeth from a non-functional or traumatically functional location to a physiological functional one. To move teeth to a position so that when restored, they will be most aesthetically pleasing. To move teeth in a direction and to a location to increase the dimension of available structure for resistance and protection form. To create sufficient space for the thickness of matrix band. Tooth movement can either be rapid or immediate, or slow or delayed. Rapid or immediate tooth movement is achieved through mechanical type of separation, creates either proximal separation at the point of separator introduced and or improved closeness of proximal surface of opposite side. It is either a preparatory phase to slow movement or to maintain the space gained with slow movement. Separation shouldn't exceed the thickness of involved tooth's ideal space, 0.2 to 0.5 mm. The methods to achieve this is wedge method, inserting a pointed wedge-shaped device between the teeth. When it moves spatially or lingually, there is greater separation. Elite separator indicated for short duration separation to examine proximal surfaces in final polishing of restored contact. Wedges can be wooden or plastic. Triangular anatomic form is preferable. This is for both tooth separation for preparation and restoration. Anatomic triangular wedges will have the triangular cross section, base contacting interdental papilla. The sides coincides with the embrasure, the apex towards the gingival starter contact area. Function of wedges: hold the matrix in position, slight separation of tooth, providing space for placing the matrix band, preventing gingival overhang, stabilize the matrix and retainer, assure close adaptability of band to tooth, protecting interproximal gingiva from unexpected trauma. Types of wedges can be wooden, plastic, transparent, medicated. Shape can be triangular, round, or trapezoidal. Where do you place a wedge? At the gingival embrasure beneath the contact area. They are selected based on the tooth or the embrasure which is to be engaged with the wedge. Wooden wedges are customized according to the size of the embrasure. Usually lingual embrasures are preferable for wedge placement as they are larger in size. Length is ½ inch or 1.3 centimeters. After placement, the wedge should be firm and stable. Wedging techniques: you have single wedge technique, which is one wedge which is placed, piggyback. The second wedge is placed on top of first for adequate adaptation of matrix against the margin in patients with the interproximal tissue level being receded. Double wedging, where one wedge is placed from the facial, the other from the lingual. Used when the proximal box is wide facial-lingually. Should be used only if middle two-thirds of proximal margin can be adequately wedged. Wedge wedging in areas where there is fluted roots, concavities like the maxillary first premolar. In order to wedge a matrix band tightly against such margin, second wedge is inserted between the first wedge and band. You can also use rounded cross-section wedges. Now, a triangular wooden wedge is the one which is more recommended as because of the ease to trim and adapt They absorb moisture and swell for a proper adaptation and stabilization. They are much stable for against condensation pressure of amalgam. All these are the advantages. Light transmitting wedges are plastic ones which are transparent, the light reflecting core, to be used along with transparent matrices to restore light tooth colored restoration. They will transmit 90 to 95% of incident light towards the gingival margin, thus providing a better adaptation at the cervical area in a class 2 composite. Next important point is pre-wedging. It is a procedure of inserting a wedge between the interproximal surface of two adjacent teeth prior to preparing a cavity involving the proximal wall. The purpose here is to achieve some tooth separation such that after restoration, teeth once it return back to the physiologic position, there is more positive tooth contact here. This is a very, very important aspect. Pre-wedging is something which is to be practiced by all the restorative dentists in order to avoid any discrepancy in the contact once the restoration is finished. These are the errors with wedge placement. The wedge is more occlusal and abnormal concavity is created in the restoration. If it is too apical, the matrix band is loosened at the margin and overhangs will be created. Tightness of wedge is tested by pressing the tip of explorer against the middle two-thirds of the gingival margin. That is about the wedge method. Now you have the traction method done with mechanical device which engages the proximal surface of two teeth, which is to be separated with the help of folding arms. Non-interfering true separator, Ferrier double bow separator. Non-interfering true separator is used when continuous stabilization is necessary. The advantage here is that separation you can adjust, increase or decrease after stabilization too. And this is a non-interfering type of device. So how do you apply it? Apply the jaws close to the bore against the tooth to be operated upon. Apply a piece of softened compound to teeth under separator. A wrench used to move the jaws over the approximating tooth. The nut on the facial aspect moved first until the jaw touches the surface needed, then the lingual side. Repeat the adjustment until the desired amount of separation is obtained. Ferrier double bow separator. Separation is stabilized throughout the dental operation. Separation will be shared by the contacting teeth and not at the expense of a single tooth. There are 4 arms adjusted so that each will hold a corner of proximal surface of contacting teeth, gingival to contact area, and the wrench will create the desired separation. So that's about rapid tooth movement. Then you have slow or delayed tooth movement, indicated when the teeth have drifted or tilted considerably. Rapid movements of teeth to proper position will affect PDL. Therefore, slow movement is mandatory over weeks to allow a proper repositioning of teeth. Methods of achieving this is use of separating wire, oversized temporary, orthodontic appliances, rubber dam sheet, and so on. Separating wires, thin pieces of wires are introduced across the contact area, wrapped around it, ends are twisted to create a separation without exceeding the physiologic limit of periodontal ligament space. Tighten the wires periodically until adequate separation is obtained. Oversized temporaries, the resin temporaries are oversized mesiodistally to achieve slow separation. Resin is added on unless the amount of separation is obtained. Orthodontic appliances, fixed appliance will be more predictable, removal will take a long time. Next is matricing, a procedure of creating a temporary wall opposite to the missing walls, surrounding area that were lost during preparation. Matrix should displace gingiva and rubber dam away from the cavity margin, assure isolation of cavity, provide proper shape for restoration, maintain its shape while hardening, confine the material within the cavity. Matrix is a device which is applied to a prepared tooth before insertion of restorative material to help in creating proper contour and to confine the material. So it will help restore the proper anatomy, contact and contour. Matrix system involve band and retainer. Matrix band is supplied as strips of various dimension, thickness of 0.001, 0.002 inches, width of 1/4, 3/8, 5/16 or 1/8. Depending on the height of proximal surface, suitable size will be selected. Retainer, the device by which a band can be maintained in its designated position and shape. Either it is a mechanical device or it can be a dental floss or an orthodontic wire or even impression compound. These are the qualities of a good matrix. There should be adequate rigidity, help in establishing a proper contour, preventing gingival overhangs, ease of application and removal, and it should be economical. Matrix system is classified based on mode of retention as those with retainers and without retainer, based on the type of band as metallic and non-metallic, based on the type of cavity, class 1, double banded Toffel-Mayer Barton's matrix is used. Class 2, single band Toffel-Mayer, Ivory 1, 8, copper band and auto matrix. Class 3, mylar strip and S-shape matrix. Class 4, mylar strip, transparent crown form, modified S-shape. Class 5, window matrix and cervical matrix. Toffel-Mayer is a universal matrix system introduced by DR Toffel-Mayer for Class 2 restoration. Advantages: it can be placed facially or lingually. Retainer and band are stable when in place. It can be separated easily and can be held in position too. Matrix bands available are either uncontoured, which needs to be contoured with suitable instrument, or pre-contoured, which are a bit expensive but easy to apply. Supposing if the matrix is not contoured, you need to shape it with the help of number 26 or 28 varnisher. Place the band on a resilient paper and with the instrument used with firm pressure in back and forth motion until the band is deformed occlusogingivally. After the band is deformed, the large egg-shaped end is used to smoothen the varnished band. Clinical application: damaging gingival attachment should be avoided. You can modify the band if the marginal gingiva is deeper, trim it accordingly if it is shallow. They should position such that it is 1 mm apical to gingival margin or deep enough to engage by the wedge 1 to 2 mm above the marginal ridge. Now regarding the ivory matrix number 1, to restore a unilateral class 2 cavity, the band is attached to retainer with a wedge-shaped projection. The screw is adjusted at the end of retainer so that they are adapted to the proximal contour properly. Ivory number 8 consists of band which encircles the entire crown for a bilateral class 2 cavity. Black's matrix: for simple cases, the metallic band is cut at according to the extension of cavity, and they are held in place with a wire or a dental floss. Lax matrix with gingival extension. According to the cavity, you will select the suitable matrix, and the corners are shaped so that they doesn't affect the gingival margin.